higher localized ascorbic acid concentrations compared to systemic delivery. That makes sense, right? If you go right to the tumor, you're going to be able to deliver more ascorbic acid, or more of anything for that matter, unless you just automatically reduce the dose, which by the way, you can, because you're going right to the tumor. And you're completely bypassing the limitations of that plasma to extracellular space, to tumor microenvironment, to totality of tumor, and then tumor burden. You're bypassing all of that. It's like chemotherapy. If you go right into the tumor, it bypasses the off-target toxicity of the systemic chemotherapy. I mean, it makes sense. But here, actually, in study of mice, they actually showed that the intratumoral administration achieved higher local vitamin C concentrations compared to the systemic delivery. Yet, what you now heard there and now know from a 2012 study, good luck finding a doctor that knows that. Good luck. And that's my problem, because we doctors must teach doctors. And it's a science problem, because science is not about propagating a narrative. It's about propagating the science, the truth. The pro-oxidative mechanism of the vitamin C was generated by the hydrogen peroxide. And this intratumorally or systemically was still proven to be the case, the primary effect here of the cancer-killing effect. So the conclusion was this: high-dose ascorbic acid, particularly through the intratumoral delivery technique, demonstrated significant anti-tumor activity in vivo, suggesting its potential as a localized cancer therapy. 2012. Now, the limitation was this was an animal model, and it's not a human model or a human study for cancer treatment. So we have to recognize that animal studies don't always translate to humans, but we have plenty of human studies of the systemic benefits of vitamin C that, you don't want to say take it to the bank, but take it to the bank. Then the next study here is, we'll go back just a little bit more, 2008. Pharmacological doses of ascorbate act as a pro-oxidant and decrease growth of aggressive tumor xenografts in mice. Now, the objective here was to examine the effects of the pharmacological doses, I've used that word before, of vitamin C on the growth of aggressive tumor xenografts. Now, tumor xenografts are a transplant of an organ, tissue, or cells to an individual of another species. And this was established in immune deficient mice, and they implanted aggressive cancer cell lines. So they took human cancer cells and implanted them in immune deficient mice. The higher doses of ascorbate, that's ascorbic acid, vitamin C, were administered then IV and intratumoral. So again, looking at both. The study measured tumor growth, survival rates, and biochemical markers of oxidative stress. So this study was looking at both in vitro and in vivo. So here are the key findings of this second study. High-dose ascorbate selectively decreased tumor growth without affecting normal tissue. Boom. See, I've talked about this a lot. Natural therapies have the capacity to target abnormal cells in abnormal areas and protect and preserve healthy areas. The therapeutic effect was mediated by ascorbate-induced hydrogen peroxide formation, which caused oxidative stress in the tumor microenvironment. Normal cells were left unaffected. And it was due to their robust antioxidant defenses, just like the IV in the blood. It had the catalase, the glutathione peroxidase. Same thing in healthy cells. So giving vitamin C, it can be pro-oxidative and antioxidative in the same body. Intratumoral delivery achieved localized pro-oxidative effects with enhanced tumor cytotoxicity. So 2 studies looking at both. Third study, the potential use of ascorbate in the treatment of cancer, published in Anti-Cancer Research 2009. The objective here was it was a review to look at the potential of ascorbic acid as a therapeutic agent in cancer treatment. And they looked at different mechanisms of action, but at the pharmacological dose, ascorbate generates hydrogen peroxide in the tumor microenvironment. Already referenced that. And it induced oxidative stress and cytotoxicity in cancer cells that have deficient detoxification enzymes, particularly catalase and glutathione peroxidase, and even superoxide dismutase. Both systemic, that's IV, and localized intratumoral delivery methods were discussed in this review article. And they discussed that intratumoral administration probably was the best delivery technique because of, again, the obvious, the direct high localized concentrations delivered right there. Pretty easy, right? Pretty easy. So their potential benefits they recommended was the synergistic effect of chemotherapy and radiation, meaning the benefit of pharmacological vitamin C, whether at IV or intratumoral, with chemo and with radiation. Talk to your medical oncologist. Talk to your radiation oncologist. They're going to tell you not to because it's an antioxidant. And here's the research that's saying, no. All to the contraire. Read the research. It's minimally toxic to normal tissues, even at high doses. Let me repeat that. Minimally toxic to normal tissues, even at high doses. Why? Because the high doses have the capacity to detoxify it. They have the capacity to handle the electron donation, redox buffer. The cancer cells don't. And it has anti-angiogenic properties, reducing tumor vascularization. So all of that background, that history of those studies talking about intratumoral, to bring you to a recent article entitled In Vitro and In Vivo Assessment of High-Dose Vitamin C Against Marine Tumors. Now, this was an animal model, and they looked at female mice aged 8 to 10 weeks, and they used two types of marine cancer cell lines. So they employed breast cancer cells and colon cancer cells, particularly 4T1 breast cancer cells and C226 colon cancer cells. Now remember, a marine model is cells that are not from mice injected into mice. And that's exactly what here. They took human cancer cell lines and injected them into the mice. So it's one species to another to follow a biological phenomenon. Then what this did is induce tumor induction. And what we saw is the subcutaneous inoculation of these tumor cells into the flank of these mice grew tumors. And they followed these tumors until they reached 90 cubic millimeters in volume, in milliliters, okay? And this was typically about 8 days after the inoculation. And then they divided these mice up into three groups. The control group, which received no vitamin C, then the low dose group, which received 100 micrograms per mil of intratumoral vitamin C, and then the third group, which the high dose, which delivered 200 micrograms, which delivered and then received the 200 micrograms per mil of intratumoral vitamin C. So again, we had two parts to this study. The first part is you implant the tumor. You let the tumor grow. The second part is you say, okay, let's divide it up to the treatment group that receives no vitamin C, just placebo. Second is low dose intratumoral vitamin C. Third is high dose intratumoral vitamin C. Again, low dose 100 micrograms per mil, high dose 200 micrograms per mil, but understand they dosed it all the way up to 1,000 micrograms per mil. And these intratumoral injections were right into the tumors. This was not IV. So here's what they found. They found that both the low dose and the high dose vitamin C treatment groups resulted in significant delay in tumor growth compared to the control group. The high dose group exhibited a more pronounced tumor growth inhibition. So the control group, where they injected nothing but probably saline, no change in tumor growth, right? The low dose, actually, you had a reduction in tumor proliferation. The higher dose, you had a dose-dependent increase, reduction in tumor growth. And no significant toxicity or adverse effects were observed in the mice receiving the intratumoral vitamin C, up to 1,000 micrograms per mil. The treatment was well tolerated and had a very high safety profile. See, that theme has been reproduce. Yet here we are talking about vitamin C again. The in vitro findings resulted in inhibition of tumor cell proliferation. That's growth. Now, this suppressive effect was seen within 24 hours, meaning from intratumoral vitamin C injection, we saw these cells' growth inhibition start at 24 hours. That's quick. And this persisted over time. So imagine you go higher dose intratumorally. You're going to see this effect occur early, and you're going to see it continue, probably dependent time-wise on the dose given. It induced apoptosis And so the vitamin C, we know, can trigger programmed cell death here, apoptosis. And it did so in a dose-dependent manner, meaning the higher the dose, the more apoptosis it triggered, programmed cell death in these cancer cells. They showed that the increased early and late apoptotic cell fractures were associated with a higher vitamin C concentration. So the earlier the programmed cell death that occurred, it was associated with the higher vitamin C concentrations injected, again now, intratumorally. Other findings, the intratumoral vitamin C was synergistic with chemotherapy. Real quick, synergistic is not additive. Additive is 1 + 1 = 2. So that would mean intratumoral vitamin C plus chemo equals 3. No. Synergistic is 1 + 1 = 10. It's an exponential benefit. Combining vitamin C with chemotherapy, that's intratumoral vitamin C with chemotherapy, here particularly the drug cisplatin, enhance the anti-tumor effects compared to either treatment alone. It also had immunomodulatory effect. We talk about immunostimulating, immunosuppressant, but here it's modulating the immune system, which means it can have an immunostimulating effect here and an immunosuppressing effect here. And you go, wait a second, I've never heard of that. What about something called a selective estrogen receptor modulator, such as tamoxifen in cancer? It can have an immunostimulating effect with estrogen receptors here and an immunoblocking or suppressing effect with estrogen receptors somewhere else. So in the immunomodulatory effect of the intratumoral vitamin C, it found that it modulated the infiltration of T cells into the tumor microenvironment. It increased the infiltration of T lymphocytes. Now, what's important here is it required a competent immune system. So if you have an immune deficient mouse model, or you have an immune deficient individual, if we extrapolate it out, that we may not see as much of a immune infiltration of the T lymphocytes into the tumor microenvironment. But here's the other thing. It augmented it augmented the immune checkpoint inhibiting therapies. So the intratumoral vitamin C augmented conventional immunotherapeutics, particularly the immune checkpoint inhibitors such as Keytruda, Opdivo, Yervoy, etc. And you can find that reference from a 2020 study entitled High Dose Vitamin C Enhancers Cancer Immunotherapy. Now, what's also interesting here is they proved the positive, the intratumoral vitamin C. Then they proved some of the negative, which is they added N-acetylcysteine, and it countered the pro-oxidative effect of the intratumoral vitamin C in the tumor. Now, it lost this at the really high levels, at the high dosing, that is the 1,000 micrograms per mil of intratumoral vitamin C. But the N-acetylcysteine counteracted the pro-oxidative effects of the vitamin C intratumorally. I've talked about, N-acetylcysteine, it's not a great therapy to use alongside IV vitamin C when you're using it pro-oxidatively to try to directly cytotoxically kill cancer cells. The same also applies here in this mouse model, saying it also applies to intratumoral vitamin C as well. So, different doses of vitamin C, different delivery methods of vitamin C. If we want to target cancer, oral route, no, it's not a good route. IV route, great route. Now, it does have some issues we have to bypass. All those variables of inflammation, of redox balance, oxidative stress, tumor burden, body weight, all of those things limit the variability. Tumor burden is probably one of the biggest one of the IV route. And that's why, the systemic to tumor route of delivery of therapies in cancer, I think, is flawed. It's what we've known. And, a lot of times what you see in medicine is what you see in so many aspects of life. You do what you know. It doesn't mean it's right. It's what you were taught. Maybe those who were taught, maybe it was wrong. They just didn't know it. It's what they were taught. But here, the intratumoral vitamin C in this 2016 study suggests we can kill cancer cells in a dose-dependent manner. We can augment chemotherapy. We can augment immune checkpoint inhibiting therapy. Now, that was from another study, but it's a standalone therapy, but it's a therapy that's going to work alongside other therapeutics by going intratumoral, starting at a low dose of 100 micrograms per mil and go up to 1,000 micrograms per mil. But here's the best part, is it'll augment other cancer killing therapies. It'll kill cancer cells. It'll modulate the immune system to do it. It'll augment immunotherapies. but it protects and preserves healthy cells. Win-win. Win-win. It's a great therapy. So here's the conclusion. The studies suggest that high-dose vitamin C, when delivered directly into the tumor, it serves as a new therapeutic approach for advanced tumors for the ability to inhibit tumor cell proliferation directly, induce apoptosis directly in a dose-dependent manner, and to enhance the effects of chemotherapy. I would add immunotherapy as well. Direct intratumoral delivery of high-dose vitamin C effectively delays tumor growth in this marine mouse model. Now, that is a limitation. It is a mouse model. It's not a human model. Now, this was a breast and colon cancer. But given its low toxicity and accessibility, and I would say the reproducibility of the systemic IV vitamin C that correlates with the intratumoral here in this mouse model, this approach holds great potential as a novel therapeutic strategy for patients with advanced tumors. But I always love how studies do this. Further research is warranted. When does further research become enough? That's kind of the CYA. When you're really proposing a new idea, a new concept, you go, whew, boy, things might get really hot with that bullseye on my you-know-what. So let's throw in a CYA comment, and that is further research is warranted. That's the CYA comment. So the future of vitamin C? I'm a big fan of IV vitamin C, and I think you can definitely use IV vitamin C in conjunction with intratumoral, but I think the future of vitamin C, it is the intratumoral vitamin C delivery method. To use it in conjunction with intratumoral immunotherapeutics, like what we do at the Williams Cancer Institute. And we do intratumoral chemo and intratumoral immunotherapeutics, both immune checkpoint inhibitors and low-dose chemo. And by going intratumoral, we could actually lower the dose of the vitamin C. So it's going to reduce the adverse effects. You can have off-target toxicity with chemo immune checkpoint inhibitors. Vitamin C has been shown to reduce that, but we can also put those together at lower doses, keep that in the tumor, and really limit all off-target toxicity effects. Empower the immune system to do the job locally, train it, harness it locally, and allow it to spread systemically. That's the beauty of the aposcopal effect. And I believe intratumoral vitamin C is right there. It's the power of vitamin C, but that's the power of this new delivery methodology that I believe you're going to see coming to you very, very soon. So look for more information on this at the WilliamsCancerInstitute.com.